Thank you very much for the opportunity to present our work on COVID-19 ARDS and their phenotypes. I would like to thank my co-authors who made this possible. Acute respiratory distress syndrome, or ARDS for short, has been described over 50 years ago. Even in the first publication, it was noted that whilst the clinical features of the disease were very similar in all patients, the precipitating factors and the responses to treatment were different. Since this first description, ARDS has been studied extensively, and through different definitions of the syndrome, we have a better understanding of outcomes and treatment opportunities. Very recently, our co-workers, Pratik Sinha and his colleagues, described that patients with ARDS can be categorized into two distinct phenotypes, based on the extent of their inflammatory response, hypo and hyperinflammatory phenotypes. They have found that patients in these two categories not only had different outcomes, with the hyperinflammatory phenotype patients at higher risk of mortality, but also that the two groups responded differently to experimental therapies, opening up the possibility for the application of precision medicine in this severe condition. The original model describing the hypo and hyperinflammatory groups was derived using a statistical method called latent class analysis, which has used multiple variables to categorize the patients. It showed a very good discrimination and calibration. However, as it needed a lot of detailed data on the patient level, was unlikely to be useful at the bedside. Pratik and his colleagues went on to derive a much more parsimonious model, and as the ROC curve illustrates on this slide, they have found that using only 3 or 4 variables, they can still discriminate between the two groups with sufficient precision. As the first wave of the COVID-19 pandemic started to take foothold in Europe, there were reports of this viral infection causing a very dysregulated immune response, with significant elevation of inflammatory markers, causing a cytokine storm leading to secondary organ damage. These very early reports focused on the features observed in COVID-19 disease, which were similar to the clinical and laboratory findings in secondary hemophagocytic lymphocytosis, or HLH. An early report in The Lancet drawn attention to this, and while South Wales were preparing for the first wave, intensive care physicians were frantically talking about the potential ways to deal with the hyperinflammatory cytokine storm. At the same time, in the Royal Gwent Hospital Intensive Care Unit, we participated in the FIND study and were setting up to recruit patients to find out what are the phenotypes in ARDS. The aim of the currently ongoing FIND study is to determine if a 3-variable classifier can generate the probabilities for phenotype assignment using cytokine assays on a point-care device developed by Randox Laboratories, the evidence multistat platform. The 3 variables in this model are IL-6, soluble TNF receptor 1 levels, and serum bicarbonate. As we had the study up and running with adequate supplies of consumables and support from the wider research team, following discussion with the study office, we aimed to generate evidence on how hypo and hyperinflammatory phenotypes are distributed in COVID-19-induced ARDS. There was another centre ready to join in London, so between the 17th of March and the 24th of April, we have recruited 39 patients with confirmed SARS-CoV-2 infection needing ICU admission, 32 in the Royal Gwent and 7 in UCL, and we followed them up for 28 days. We are very proud that we could contribute to this rapidly changing field, and that our paper was published on the 27th of August in the Lancet Respiratory Medicine. I'm going to talk about the details of the study now, but please have a read if you are interested in the real minutiae of the study. All of our patients fulfilled the Berlin definition of ARDS. They all had classic ARDS type chest X-ray or CT changes. The patient population was representative of the UK critical care population during the first wave of COVID-19, with a male predominance and a much higher than average representation of ethnic minorities. We found statistically using the Yoden index to derive the probability of phenotype distribution. We had 31 patients in the hypoinflammatory group and 8 patients in the hyperinflammatory group. We found significant differences in the creatinine and LDH levels between the two groups. The hyperinflammatory group also had higher APACHI2 scores on admission. However, other clinical parameters, such as ventilator settings, oxygenation, and the need for rescue therapies or the need for vasopressor therapy, were not significantly different between the two groups. To examine if the phenotype distribution is different in COVID-19 and general ARDS, we have used data from a previous study, the HARP2 trial. In this study, phenotype distribution was determined either via the latent class analysis or via a parsimonious model. Some of the patients in the HARP2 trial have had their inflammatory markers measured by point-of-care assay too. We have found 39 patients in this HARP2 cohort who not only matched our patients by age and sex, but also had their inflammatory markers measured on the same platform. We found that whilst the distribution of hypo and hyperinflammatory phenotypes were similar in both the HARP2 matched, and the COVID-19 groups, mortality was much higher in our COVID-19 cohort. When comparing previous ARDS cohorts with our COVID-19 patients, we have found significantly lower APACHI2 scores in the COVID-19 group, significantly lower soluble TNF receptor 1 levels in the COVID-19 group, very similar IL-6 levels, similar creatinine levels, and significantly higher platelet count in the COVID-19 group. What do these results mean? In COVID-19 ARDS, there is a cytokine breeze rather than a storm based on our results. We have found that the hyperinflammatory phenotype is uncommon after ICU admission in COVID-19 ARDS, or at least it is not more frequent than in previous ARDS cohorts. We found that the hypoinflammatory phenotype has higher mortality than in a matched cohort of non-COVID-19 ARDS patients. Our findings are supported by other recently published data from a US group. They also found that COVID-19 ARDS had similar or lower IL-6 levels, IL-8 levels, and TNF concentrations compared to other ARDS groups. Although it is possible that the inflammatory response changes over time and we have not caught the hyperinflammatory problem on day 1 of ICU admission, data from Manu Shankahari's group seems to refute that theory. They found that the inflammatory response stayed at the same level or even decreased as time passed in a cohort of COVID-19 ARDS patients. In our small and limited study, found that point-of-care determination of cytokines is feasible at the bedside. It might be directing therapy based on the previous results. However, we do still need a lot more data to correctly identify phenotypes, and ideally, we would like to have enough data to do a latent class analysis in COVID-19 ARDS, such as it was conducted in general ARDS. And finally, I would like to thank my excellent colleagues and researchers who helped me to get this study together. Special thanks go to Pratik Sinha, the first author of the study, Prof. Danny Macaulay, who is the chief investigator of the FIND study, and to Shaini Chiran and Anna Roynan-Reed, who were the excellent research nurses and research coordinators in the Royal Gwent Hospital. Thank you for your attention.